Assalamu alaikum warahmatullahi wabarakatuh. Welcome to one of our quick sessions in which we summarize together the Green Top guidelines. Our guideline today is the blood transfusion in obstetrics, very important one, of course, and mainly it revolves around those 4 points: the preventive measures to reduce the need for transfusion, the general principles of blood transfusion, and the management of obstetrical hemorrhage with blood transfusion, and some of pharmaceutical strategies for management of major bleeding, of course. We need just to know that hemorrhage is still a very major leading cause of direct maternal deaths in UK. It is the third leading cause of direct maternal deaths, about 10% of them, and it is estimated that there are about 4,000 cases every year. So it's huge. Mainly, anemia in pregnancy is defined as a hemoglobin less than 11 milligram per deciliter or in first trimester, or 10.5 or less in second or third trimester, and postpartum hemoglobin less than 10 milligram per deciliter. If you cannot demonstrate any rise in hemoglobin of your patient by 2 weeks after oral intake of iron, and you know that her compliance is good and checked before, you can do further tests, of course. Screening for anemia at booking and at 28 weeks is a must. For multiple pregnancies, you will have to add a full blood count at 20 or to 24 weeks also. I'm going through it fast because all of us know this. We all know that oral iron should be the preferred first line treatment for iron deficiency, of course. We all know that parenteral iron is used when oral iron is not tolerated or absorbed, or there is doubted compliance, or we are approaching term and there is no time for oral iron to be effective. Here is one of the new information that the guideline inform us about: the role of recombinant human erythropoietin. And this is, of course, used in non-end stage renal anemia. And actually, it is still to be established, and it should only be used in context of controlled clinical trials. And only expert hematologist should order it. And of course, active management of third stage of labor is recommended to minimize blood loss. And of course, you will tell your patient to maximize her intake of food that is rich in iron and all this stuff. Now, here comes the serious parts. What should I know about the guideline of blood transfusions? You should be familiar with the general principles of blood transfusion. Of course, as always, consent. Consent in anything in UK is crucial for anything, and consent for blood transfusion should be valid and obtained where possible prior to administering a blood transfusion. What should I do in emergency cases? You should get a consult if feasible, of course, and if it's not, you have to inform um, the caregiver or whatever with the patient with the act of blood transfusion, and record in the patient records, of course. And you should put down the reason for transfusion and document everything in the patient case notes. Okay, is there any requirements for group or screen samples and cross matching? What should I know? Because there is a lot of information about this. We just need to know that all women should have their blood group and antibody status checked at booking and at 28 weeks of gestation. This simplifies a lot for us when times of delivery comes, because as you all know, at emergency settings, and if I don't have enough data about my patient, then I will have to take emergency measures, and these emergency measures is not preferable because of cross matching, of course, and cross matching takes time. Just remember this, cross matching takes time. So I need to prepare my patient before delivery. And of course, the samples that I had for provision for my group and screen samples should be less than 3 days old. In case of emergency transfusions, as much as I can, I have to keep blood available if necessary. And if I cannot do anything, I should send at least once a week to exclude or identify any new antibody formation of my patient's body. A close liaison with the hospital transfusion laboratory is essential because of this. The easy contact between me and the hospital transfusion laboratory is essential so I can send her blood samples and get if there is any new antibody formation happened. Okay, what group or screen sample I should take? It has to be taken accordingly to the protocol of your hospital, and we will talk about it later. Is there any specific antibodies I should take care of? Yes, ABO, rhesus of course, and CAL compatible red cells units should be transfused. Um, However, if clinically significant red cell antibodies are present, then blood negative for the relevant antigen should be cross-matched before transfusion. And this is again why we should have close liaison with a transfusion laboratory to avoid, of course, the delay in life-threatening hemorrhage. This, by the way, is still a challenging point in UK because most of the deaths happen before the delay in transfusion due to waiting for cross-matching. So they are trying as much as possible to minimize this delay and to avoid this delay. So they are trying to make satellite blood banks. We will mention it later. They are trying to make the whole clinicians and the nursery staff aware of the sites of these banks. Um, the protocol of each hospital should be renewed annually, and all the staff members has to be oriented with it too. You just need to know that your red cells and platelets should be cytomegalovirus seronegative if it is elective transfusion during pregnancy. I think this is the least thing you can do for your patient. We are not talking about emergency or anything. This is an elective transfusion during pregnancy, so at least make sure it is cytomegalovirus negative. Okay. Now that's what I was talking about. The management of obstetric hemorrhage with blood components should be under clear local protocol. So be familiar with your hospital protocol and be aware of the location of satellite blood fridge if it is available, of course. Okay, what blood components can be used for obstetric hemorrhage? This is not the issue here, but it's like a revision for us that red blood cells should not be initiated for transfusion, as we all know. And honestly, the decision to provide blood transfusion should be made on clinical and hematological grounds. I don't think many of us have ever initiated blood transfusion by red blood cells. And in extreme situations, and when the blood group is unknown, please start with group ORH negative red cells. Do not wait for cross matching again. Okay, but for fresh frozen plasma and cryoprecipitate, you have to know exactly when to initiate them. For fresh frozen plasma, you have to administrate a dose of 12 to 15 milliliter per kilogram for every 6 units of red cells during major obstetric hemorrhage. How I will know this? I will know it by doing PT and APTT, and my aim is to keep them at less than 1.5 multiplying the normal value. We will take sample during operations, yes, and you will monitor your patient and decide accordingly. So for every 6 units of red cells, you will administrate a dose of 12 to 15 milliliter per kg of fresh frozen plasma. I'm talking here about major blood hemorrhage, of course. And for cryoprecipitate, there is a standard dose of 2 5-unit pools early in major obstetric hemorrhage. So this is an initiative component. I can initiate by cryoprecipitate in major obstetric hemorrhage, and subsequent transfusion should be guided by fibrinogen results, of course, and it has to be above 1.5 gram per liter. So I have cryoprecipitate to initiate with. I have fresh frozen plasma to give for every 6 units of red blood cells, and both are monitored by PT and APTT. And cryoprecipitate is guided by the fibrinogen levels. Okay, do I need to make sure they are Rh negative or Rh positive, the compatibility, and so on? For cryoprecipitate and fresh frozen plasma, it is not a must, but it will be optimum, of course, if you provide your patient with the same group as the recipient. What about platelets? Our aim for platelets is to always be above 5 billion or 50 multiplied 10 power 9 in acute bleeding patient, and take care of every word. Every word can come a question, especially in MRCOG part 2 and in scenarios for MRCOG part 3. Sometimes if the your examiner is malignant or so. So you have to know you have a limit. You cannot let the platelets go under 7.5 billion. Why? Because I need to keep it above 5. So I have to make a margin of safety, because below 5 I can go into a disaster and the cascade of coagulation will be destroyed immediately. So my margin of safety is 7.5 milligram per deciliter. The platelet should be ideally group compatible. This is a must. If my patient is Rh negative, she has to receive Rhd negative platelets. This is another information about is it a rule for near patient testing of coagulation. Some centers has it, some centers does not have it. What are those? There are centers using thromboelastography for guiding blood transfusion during major obstetric hemorrhage, and they have like transfusion algorithm protocol, and the guideline is just telling us that we has to make sure that the protocol is validated and the quality assurance measured as followed, of course. Okay, what are the pharmacological strategies for management of major obstetric hemorrhage? What they mean by pharmacological strategies? All of us know about tranexamic acids, of course. Tranexamic acids can be used, uh, but not, of course, for a substitute for blood transfusion. For those centers not participating in clinical trials, consideration should be given to using tranexamic acid during major obstetric hemorrhage. And we are talking about centers that are not participating in clinical trials. So it is not a rule for every hospital or center in UK. You cannot use tranexamic acid during major obstetric hemorrhage unless the center is not participating in clinical trials. Is fibrinogen concentrate licensed in UK? No, it's not licensed in UK. And it should not be used for postpartum hemorrhage, of course. What is the role of recombinant factor 7A? Recombinant factor 7A is a very good treatment for life-threatening postpartum hemorrhage. However, it should not delay or be considered a substitute for life-saving procedures like embolization or surgery or transfer to a referral center. Why we are talking about this? Because if you have a case and he give you choices and he wants you to make what's first, what is the first line for your patient? Would you give her or wait for recombinant factor 7A or transfer her? You will transfer her. If it's available, okay, we can use it. Of course, then refer her if I don't have the enough management to deal with her. But you should know what's first comes first. The delay for having recombinant factor 7A should not delay your decision for embolization or surgery or transferal. We have talked about how should intrapartum anemia be managed. However, I wanted to tell you that if my patient is not actively bleeding, and this is an important question, and her hemoglobin is less than 7 milligram per deciliter or 70 gram per liter, should I give her blood or not? This is a very important question. Most of us, by practice, doing it mistakenly wrong. If my patient is not actively bleeding, even if her hemoglobin is less than 7 milligram per deciliter, she does not need red cell transfusion. And there is a special guidelines on criteria for red cell transfusion in anemic women who are not actively bleeding. The decision to transfuse should be made according to the individual's medical history and symptoms. So it is not a rule. As for my practice, as for my country, we had a rule that if my patient is below 7, I will order blood for her. And this is not working in UK. This is not the rule in UK. If my patient is not actively bleeding, even if her hemoglobin is less than 7 milligram per deciliter, I will not order blood for her unless her medical history or symptoms are declining or she become unstable, of course. And if hemoglobin is less than 7 in postnatal period and there is no ongoing or threat of bleeding, the decision to transfuse should be made on informed individual basis again. So it's not a rule, it is not a must. Now comes a very important question. How should women who decline blood products be managed? Yes, there are some women you will meet who decline to have a blood product or blood transfusions. It is um, a group named JW. It's kind of Christians, and they refuse any type of blood components or transfusion sparing techniques, and you have to discuss with her uh, possibilities if there is any substitutions if there is some kind of components that her religion allow or not. Know your limits and try to be sensitive as much as you can because this is a very sensitive topic to discuss with your patient. Do not by any mean judge her decision or force her to choose otherwise. You have to respect her choice and give her alternatives. Mostly they will carry a paper like this small white paper. It is a huge leaflet. It is folded and with a very big labeled no blood on it. And if they don't have this, you have to ask, of course, your patient because, as we said, you have to take a consent. So if she refused, she have also to signature a refusal consent. Okay, what can be used in such cases? Intraoperative cell salvage is one of the most amazing techniques that can be used in management of patients who refuse allogenic blood transfusions. And I will talk you about intraoperative cell salvage technique. But first, let's have a look at the paper. And remember, you have to optimize your patient before delivery, of course. Take the consent. Use whatever you can to avert the use of bank blood and blood components. And do it early as much as you can. Be prepared. What is intraoperative cell salvage? Cell salvage is recommended, of course, when anticipated blood loss is great enough to induce anemia or when the expected to be lost is more than 20% of the estimated blood volume. I think it's becoming a famous technique in surgery, but in obstetrics, unfortunately, it's still under, it is a subject to audit and monitoring. So there is no enough data about it. Of course, a consent should be obtained for it where possible, and its use, as I said, is subjected to audit. It should be performed by a multidisciplinary team, people who are expert in cell salvage. And if you are using it during a cesarean section and you know your patient is Rh negative and you take a cord blood group and it came out positive, you have to give your patient minimum dose of 1500 international units of anti-D immunoglobulins following the reinfusion immediately. So you have to be prepared in theater with anti-D shot, and you have to put in your mind that you will take a cord sample to check if the baby is positive or negative. I'm talking about cord blood group. Uh, okay, I don't know my patient is Rh positive or negative. I'm just imagining the worst case scenario. I don't know what is my patient blood group. Okay, I know, but I want to make sure if the baby is positive or negative. I made my decision that I will use intraoperative cell salvage, so I have to be prepared at least. It's not like it's not famous, of course, like it's used in surgery. However, if you have to use it or if you have the ability to use it, just be prepared. And you have to take a maternal blood sample for estimation of fetal-maternal hemorrhage 30 to 40 minutes after reinfusion, just in case if your patient needs more anti-D. Let's sum up. Always choose the quickest way when it comes to acute cases. Do not wait for cross matching. Do not wait for compatibility. Just order or negative blood if it will take time. Optimize your patient condition before delivery. Optimize her by oral iron intake. If not, then IV transfusion. Of course, dietary intake. This is number one. And oral iron intake by tablets. Then transfusion. Then whatever you have to do before delivery, do it. Don't wait until you have a massive hemorrhage during delivery. Make sure of compatibility, of course, if it comes to RBCs and platelets. And consider intraoperative cell salvage in JW patients. They are called J witnesses. And pre-delivery autologous blood deposit is not recommended, which means you do not have to ask the family members to leave some blood in blood bank or things like this. It is not recommended at all, and the studies has detected that it does not decrease the risk of mortality or morbidity even. So do not ask family members to go have blood deposit in the blood bank. This is the end of our video for today. Thank you so much for watching. If this video was beneficial for you, please press like and subscribe the channel and give our Facebook page a visit. And of course, your comments are always welcome. If you do not like it, press dislike. It's okay. See you next time, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.